Let's take a look at mood disorders. First of all, let's do a small introduction into the topic suicide. We have a 47-year-old man who was diagnosed with AIDS recently, and after he informed his partner, she hung up and refused to speak with him. Since then, he has started being socially isolated, started drinking heavily, and also, this fact is important, he has pain from peripheral neuropathy. On several occasions, he has expressed his desire to die to his physician. Now, suicide patients usually will tell someone that they have the desire to die. Most of them, they will have given some sort of warning to someone else that they will try to attempt suicide. Against the doctor's pleas, he has stopped taking his antiretroviral medications. He's trying to kill himself. He's trying to die early by not drinking the medicine. He refuses to seek help from a psychiatrist who could treat his depression and help him cope with his illness. He views his illness as a punishment and sees no good in trying to delay the inevitable. He feels useless and beyond help. This is a typical case of a patient who is likely to attempt suicide. The patient has a chronic disease, a terminal disease in which there's no cure. The patient is in a lot of pain. He has expressed he has a desire to die, and he's taking steps by stopping his medicine. He's basically trying to die from, as you can see from this case. Let's take a look at the epidemiology. So in the USA, around 30,000 commit suicide yearly, and a staggering 600,000 attempt suicide. Men are more likely to commit suicide, almost 3 to 4 times more likely, because they are driven by success. So if there is failure in something that they attempt, if they fail in something, there's a risk that it would cause them to kill themselves. The highest rate in both men and women are in the elderly. Now, this is very important. We might assume that younger people, young adults, are more likely to commit suicide, but in reality, it is the elderly who commit suicide more. And in both men and women in the USA, firearms are the primary method of completing suicide. And women use pills such as acetaminophen to attempt suicide. If you go to the hospital, almost daily there will be at least one patient who has come from an overdose of these drugs in an attempt to kill themselves. And this is also an important point. The adolescent suicide rate has been increasing because there's more society pressure on them to start earning, to take on the roles of adults. The best prevention for suicide is to identify and address the underlying mental illness or the substance abuse. Substance abuse is very commonly associated with suicide. And physicians, doctors, have a higher suicide rate than the general population, most commonly in vets. Now, this important point. Serotonin is associated with lower serotonin levels. As we know, serotonin is considered to be the happy hormone. And the main reason you would kill yourself is if you are lacking serotonin. When we talk about depression, we'll see that serotonin is the culprit behind depression. There is a mnemonic in the USMLE first aid book. It's called SAD persons. These are the risk factors for suicide completion. Again, first, sex, males. It's 3 to 4 times more likely that males would complete suicide. Age, it's most commonly in the elderly. And in Native Americans, you can see it in the young adults. Patients with depression have an increased risk of suicide, but the most important thing is they have the need to kill themselves, but they don't have the energy to do it. So when we learn bipolar disorders, we will learn that we should never give bipolar patients when they are going through depression, antidepressive medicine, because once their mood is elevated, they have the energy to go and kill themselves. And the number one risk factor is a previous attempt. This is the most important risk factor. So if a person has already attempted it once, it is most likely that they will try it again. Again, ethanol and drug use, especially seen in patients with depression or chronic illnesses, they have a higher risk of completing suicide. And when there's loss of rational thinking, such as in psychosis, if they have a sense of hopelessness, like a poor person will blame the world for being poor, for not having the money to live a proper life. And the rich usually blames themselves. Sicknesses. Patients discharged from mental hospitals have an increased risk up to 34 times, but also patients who have AIDS, ALS, Huntington's, when you know there's no cure, especially in Huntington's, these patients know that they're going to die. And most of the time they will have seen a family member go through this disease. They will have seen the way their parents would have deteriorated. And they know what's coming for them. So there's a very high risk of suicide in these patients. And if you watch the TV show House, season 4 will talk a lot about about Huntington's disease. And in season 6, there is a doctor who completes suicide. There has to be an organized plan. We will talk a bit about this in a while. And if there's no body to support the person, if the person feels alone, there's a higher risk. And stated future intent. This is very important as a doctor to recognize. You need to identify this. And let's take a look at how we identify this. When you as a physician talk to a patient, it could be a patient who has just attempted suicide, or it could be a depressed patient. Any disease in which there is a risk of suicide, you need to direct question them. You can't ask open-ended questions. You need to directly ask them if they are suicidal. There's ways you can ask them, but you need to directly ask them. These cannot be open-ended questions, and this is very important. This has to be done directly. Now, methods of suicide. There's something important here. Suicide is attempted in isolation. A person who's actually depressed and is actually willing to die would never do it in front of others because they don't want to be saved. If someone says they're going to die, I'm going to kill myself in front of everyone out of anger, it is most likely they are doing it as a show, knowing that someone will try to save that person. And these suicide attempts are usually almost always pre-planned and may have previous attempts. After the previous attempts, they will still regret survival. Now, there's a very funny, sad story where a group of doctors and the attending were discussing a patient who has tried to attempt suicide by stabbing himself with a knife. In front of this patient, the physician has asked the question, why do you not dislodge the knife from this patient? Why do you not dislodge the knife without taking the patient into surgery? And the students in front of the doctor has answered, because the patient will bleed out. The patient was listening to this, and what he did was he took out the knife and killed himself in front of these doctors. So be careful when you talk in front of a patient like this. Married people have a lower risk than unmarried because they have partners who will support them. And unemployment increases the risk. What is considered a serious suicide attempt? It is done in isolation and they don't seek any help. They have a plan, suicidal notes, and they regret survival. These are patients who actually want to die. And also, there is a genetic risk if there is a family member who has died of suicide, there is a familial tendency that it could happen to you or someone in your family. People at risk, there could be early traumatic events, psychiatric disorders such as depression, schizophrenia. We'll talk about these. Physical disorders, knowing that they're going to die, such as cancer, psychosocial crisis, loss of a job, all of these. And also, most importantly, there has to be an availability of means. How do you manage suicidal patients? Will you manage the patient in the hospital or in the community? This has to be done by assessing the patient to see if they still have suicidal intent, to see if that patient has proper support, see if the patient regrets this and is willing to change. And in the community, there should be a proper structure for the management. In the hospital, there are general requirements. There are specialized treatment facilities to reduce suicide risk, where they would have blankets which would tear off easily if they try to hang themselves, stuff like that. And in the environment that they are being treated, the workers must always be careful when they approach the patient. They should always take care of how they speak, how they act. They should show a lot of care. And on admission, you need to assess the risk. So there should be hourly checks, supervision, and on discharge, there should be follow-ups. And a plan if the patient does not show up. You can ask the patient to give contact numbers of family members, things like that. How do you prevent suicide? You provide more accessible psychiatric services. You destigmatize this topic. You restrict means of suicide and educational programs. Next, let's take a look at depression. Unipolar depression, severe depression, or major depressive disorder, MDD, major depressive disorder. This is a condition, a psychiatric condition, in which a patient has no energy, has a depressed mood, lacks any sort of enjoyment. So let's take a look at this case. A 40-year-old woman was recently admitted after her son informed the doctor she was doing very poorly. The patient has a 15-pound weight loss, decreased concentration, feelings of hopelessness, and decreased energy. Now, in major depressive disorders, the symptoms, the depressed mood must last for at least 2 weeks. And almost all patients will resolve by 1 year without treatment. The average duration of depression is around 6 months. But almost all patients will recover within 1 year. The problem is, if you don't treat them, there's an increased risk of suicide. So even though it can self-resolve, you need to treat them. These patients will wake up depressed, they stay depressed, and go to sleep they will go to sleep depressed. They will not have any interest in activities or energy to partake in. So basically, these patients do not have any sort of happiness in them. They are not happy with anything. So in a case study, you will hear of a patient in which nothing seems to make them happy. They have depressed mood. This is the criteria that you need for diagnosis. They should have depressed mood, loss of interest and enjoyment, reduced energy, and decreased activity. This is the main criteria, and there is the minor criteria with reduced concentration, reduced self-esteem, ideas of guilt, unworthiness, pessimistic thoughts, ideas of self-harm. All patients who are depressed must be evaluated for suicide risk. Disturbed sleep and diminished appetite. So mild depression can be classified if there's at least 2 of criteria A and 2 of B. Moderate 2A, 3B, and severe all of A and at least 4 from B. Usually, the physical findings when you examine the patient are within normal limits. The patient may complain of insomnia or hypersomnia, where they sleep too much. There could be a condition of major depressive disorder with psychosis, in which we will talk about psychosis. They are agitated, they are anger prone, and these patients have a worse prognosis. They will have a loss of sex drive, suicide ideation, and also cortisol. High levels of cortisol, such as in Cushing's syndrome, can cause depression. There is a very important type of depression called atypical depression, in which the patients complain of their limbs feeling like it's stuck in cement. The moment you hear this, that their limbs feel very heavy, if they talk about the limbs, think atypical depression, because the treatment is different. Genetic factors. A family with a history of depression increases the risk for a person to have depression. And it is also important to know that you need to know the medication used by the family members and see if it works or not. Endocrine disorders. Hypothyroidism can lead to a depressed mood. Substance abuse, such as alcohol. Physical illnesses can cause depression. Medications, personality, it could be we will talk about personality disorders. It could be part of the personality. Relationships with other people, loss of parents, some event which caused them to be depressed. Social factors such as poverty. And you can do testing for hypothyroidism. If the TSH levels are normal with treatment, you will have to evaluate the patient further for depression, not hypothyroidism causing depressed mood. Complications of depression: increased risk of suicide, self-harm, substance abuse, and a poor quality of life. They don't have the energy to live a normal and a happy life. The treatment for depression is both pharmacological and non-pharmacological. Usually there's a lot of social services which help these patients, but there could be in-hospital care if there's a high risk of suicide, and patient education, relaxation techniques. If the patient has a high risk of suicide, you need to do electroconvulsive therapy. For now, think of electroconvulsive therapy as attaching electrodes to the patient's head and passing electrical currents. For now, assume that when we talk about treatment, we will go through this in detail. We can use tricyclic antidepressants and SSRIs for the treatment of depression. Again, we will talk about these later. And the drugs must be given for a minimum of 6 months. And then, after the patient is fine, there's no depression, you need to give 6 more months. The thing about depression is depression recurs. A person who has had depression once is likely to go through depression again. Like I said, for atypical depression, if they have lead-in paralysis, the limbs feel like they are stuck in cement, you need to give them MAOIs such as phenylazine, these drugs. And you need to follow up on the patient. What is the suicidal risk? Is the patient trying to exercise or any other treatment that you give? Relaxation methods? Is the patient compliant on the drug? Etc. Next, let's take a look at different subtypes of depression. We will draw some mood charts. If this is the mood chart, and as you go up, psychosis increases. And as you go down, depression increases. The major depressive disorder will have the patient's mood somewhere here, if this is the normal level. But when we talk about persistent depressive disorder, it was called dysthymia. These patients will have depressed mood, not to the level of MDD, but this depressed mood lasts more than 2 years. To diagnose a patient as PDD, the depressed mood must be over 2 years. So we can check this case here. A 30-year-old woman complains of persistent fatigue over the last 5 years. She feels unhappy all the time and does not have the energy to do anything except the bare minimum on most days. She says she doesn't find anything that she enjoys, and when asked about suicidal thoughts, she says she has no such ideation. Now think of that as you need to be at least here to get suicidal thoughts. These patients usually do not have suicidal intent. This is a chronic disorder. It lasts more than 2 years. And let's take a look at cyclothymic disorders. These patients have a cycle of feeling great to feeling depressed, but never to the level of mania or to MDD. So let's take a look. This patient has a 12-year history. Again, we need this disorder to be present at least 2 years for diagnosis. Of feeling great followed by episodes of feeling lousy. So it's cyclothymic. It's cycling between the high elevated mood to a depressed mood. During her feeling great period, she has experienced increased sexual drive, euphoria, and increased irritability. When she feels lousy, she experiences insomnia, fatigue, and low self-esteem. This is what you call cyclothymic disorders. So we can see here another case. A 30-year-old man is brought to the psychiatrist because his wife says that he has been feeling down for the past 2 years. He has no history of major depression, but has had difficulty concentrating at work. Last month he was full of energy. Again, he has shifted from one to the other. And there's no mania episodes or psychosis episodes. This is just the patient is full of energy. The patient reports that his mood has been fluctuating this way for several years as cycles of up and down. This is a cyclothymic disorder. Let's take a look at depression with atypical features. Normally, a depressed patient will lie in bed, not fall asleep. They will be thinking about things, but in depression with atypical features, they are oversleeping. They sleep a lot. They have increased appetite. And most importantly, in a test case, they will always tell you about this condition. The patient will complain as if their hands are stuck in cement. Something heavy is pulling it down. And this is the most common subtype of depression. Now, earlier I said that MAOIs are effective, and it is the treatment such as isocarboxycid, phenylicine. I told that earlier. But in the real world, we treat them with cognitive behavioral therapy and SSRIs. For exams, you use an MAOI. If the option comes SSRI or MAOI, you go for the MAOI. Major depressive disorder with seasonal pattern. Symptoms of depression occurs during the winter months. So during the cold season, these patients will have depression, and it should happen for at least 2 or more consecutive years. There's a hypothesis that this is related to melatonin, and these patients also have the atypical symptoms. Next, let's take a short look at mania. Now, sorry about this numbering situation here. I usually take these notes from my book into a new document, and when it happens, there's a lot of renumbering. All of these problems come, so that's why these happen. Mania is when the person is full of himself. Think of it like that. The person has increased self-esteem, grandiosity, and is easily frustrated, does not need to sleep because he has other things to do, flight of ideas, that mind is always racing, new ideas, new thoughts, all of these. They get themselves involved in a lot of activities. They have too much energy that they can't just stay around doing nothing. They have to go and do something. There's going to be weight loss, and they don't want to eat, anorexia. They have uninhibited behavior. They would spend a lot of money. And also, there is increased libido. This is the major reason why these patients do not adhere to medication. Mania, to a point, is good because it increases goal-oriented activities. But these people are very difficult to live with. And there's a higher risk if a parent has had the diagnosis of bipolar or MS. Now, when we learn bipolar, we will learn that mania equals bipolar. Keep that in your mind when we go to the next chapter. So these patients will have increased irritability, euphoria, then their cognition is, they have grandiose delusions, easily distracted, lack of any insight. They don't know their true capacity. They don't know what their level is able to achieve. They think they are the best. Rapid speech. This is a very important symptom. This is called pressured speech. Sorry. These patients will be talking, and it will be just talking. Especially when you are performing a physical examination, you will always say that these patients cannot stop their mouth. Sometimes you see hallucinations. Features of mania can occur in other conditions such as infections, brain tumors, hyperthyroidism, but then there's no grandiosity and there's no disinhibited behavior. Lupus, amphetamine and cocaine toxicity, and in strokes. The management is usually to counsel them and tell their family, take away his bank cards. And you need to assess the risk of self-harm. Pharmacological treatment. So these patients have increased mood. So they have increased mood. You need to bring them down with antipsychotics. And also, sometimes you may need to give these patients antidepressants if you depress the mood too much, that you need to bring it up. We will talk about this in bipolar disorder. The main thing is you need to stabilize the mood with lithium, carbamazepine, sodium valproate, benzodiazepines. We'll talk about these in a while. Hypomanic episodes are symptoms of mania. If this is mania, hypomania is somewhere here. These patients have increased energy. They don't usually have marked social impairment, and they do not have any psychotic features. They don't have grandiose delusions, but they have increased energy, which lasts for at least 4 or more consecutive days. Now, let's talk about bipolar disorder. And what you need to know is mania equals bipolar. Bipolar, from the name you can understand, is the fluctuation between both psychosis and depression. So the person's mood fluctuates. There could be periods of normalcy, but usually it fluctuates between the two. And there's 2 subtypes. Bipolar 1 is when the mania is more prominent. Bipolar 2 is when the patient has hypomania plus depression. So bipolar 1 also has depression, But the patient's mania is very prominent. Bipolar 2 patients, they have depressive episodes and hypomania episodes. Again, these patients should never be given an antidepressant without an antipsychotic. We will talk about this in a while, because when these patients are depressed, so a patient comes and you diagnose the patient as depressed, but in reality the patient is a bipolar patient, and you prescribe an antidepressant. So the moment their mood goes up, they now have the energy to go and kill themselves. So you need to make sure when you are diagnosing a patient as depression, you need to also evaluate if the patient has bipolar. You ask if there were periods of increased energy or if there was any mania symptoms. Again, the mean age of onset is late 20s, 30s, and it is common in high socioeconomic status people. There's a strong genetic linkage, and it equally affects both males and females. This can coexist with major life changes. So these depressive episodes or these psychotic episodes, these mania episodes, usually occur when the patient has a lack of sleep. When the patient hasn't slept for a long time, the patient is more prone to go into a mania episode. Here are the differential diagnosis: schizophrenia, substance abuse, anxiety disorders, borderline personality, temporal lobe epilepsy, hyperthyroidism, all of these. Treatment: you need to assess the risk of hospitalization. You check their suicide ideation. Is there a risk of killing themselves, or is there a risk of danger to others? This is mania we are talking about. If there is a danger to others, then you need to bring the patient to the hospital. And also if there is any loss of control. You need to rule out medical conditions such as hyperthyroidism. And the first line treatment is mood stabilizers. So lithium, valproic acid, this is an anti-seizure medication. And carbamazepine, one thing you need to know, there's an increased risk of Stevens-Johnson syndrome. And lamotrigine. Then you can give these patients atypical antipsychotics, but you never give antidepressants to these patients unless it's with an antipsychotic, because once you increase the mania, you increase the suicide risk. And if there's a suicide risk, you can go for electroconvulsive therapy. Let's begin our case discussion. We have a 38-year-old man who comes to the office after a 4-week history of severely depressed mood, loss of motivation, loss of interest, and sleeping for 14 hours. Now, if you want to try these questions yourself, just pause the video, you can try it, and then you can continue. This patient has no suicidal thoughts, and the patient has had previous depressive episodes that responded well with an SSRI. He felt really good and energetic. A few days into the treatment, and the patient discontinued the antidepressants after a short period. Now, the role of antidepressants is to bring your mood up, but this patient has had his mood go really high. This seems to be a bipolar 2 patient. There's hypomania, where you get increased energy without the psychotic symptoms, without the crazy symptoms. Hypomania, and also we have the depressive episode. Which of the following is the most important to assess prior to initiating pharmacologic treatment? You need to assess this patient to see if there's a history of mania. If you are starting an antidepressant, you need to always assess the patient for a history of mania. A 25-year-old woman comes to the office due to depression. She lost her dog last month, and she has been extremely sad and has had difficulty getting out of bed. Let me highlight last month. She described sleeping 16 hours a day, increased appetite, and a 4.5 kilo weight gain. She has had similar episodes at the age of 20 to 23. She also describes brief periods of being uncharacteristically confident and optimistic. Felt well rested and energetic despite sleeping only 2 to 3 hours a night. This seems to be bipolar 2 patient. There's no excess mania, there's hypomania, and there's also depressive symptoms. Now, you might wonder, why is it not cyclothymic disorder? It all seems to be that because there's slight mood elevations and slight depressions of mood, but this is a continuous disorder. The symptoms must last continuously for 2 years. She has episodes. Next, a 25-year-old man comes to the emergency department by his wife. Is brought to the emergency department by his wife. She says that he has been acting crazy for the past 2 weeks. He has hardly slept for the last 7 days and instead has worked on miscellaneous projects around the house. The patient has spent a lot of money to get tools to complete these tasks. When questioned, he has pressured speech. He feels spectacular and is creating a masterpiece. This is mania. The long-term management for this patient is a mood stabilizer, such as lithium or valproate or carbamazepine, and we have the answer here. A 28-year-old woman is brought to the office by her husband. He says that over the past 2 months, the patient has been increasingly depressed to the point that she rarely gets out of bed. She has called in sick to work but does not answer the phone when her friends call, and has lost weight. The patient has a history of 2 psychiatric hospitalizations, and she was hospitalized due to extreme irritability and agitation that lasted a week. At that time, she had pressured speech and started saying things such as she stayed up dictating letters talking about a solution to world hunger. She was hospitalized for severe depression and a suicide attempt. She responded within days to venlafaxine and discontinued the medication shortly after discharge because she felt fine. On mental status examination, the patient shows a depressed and tearful affect. She admits to auditory hallucination. Which of the following is the most likely diagnosis? This person has episodes of mania. It's not just increased energy. They have delusions. They have increased activity which do not make sense. And again, we have auditory hallucinations, but this patient also has pressured speech. The answer is bipolar 1. A 28-year-old woman comes to the office due to persistent fatigue over the last 4 years. She has felt unhappy during this period, ever since being fired from her previous job. The patient says she has little energy to do things. This seems to be depression. When asked what she enjoys, she replies that everything in life is a chore and that she feels hopeless that her life will improve. The patient has no suicidal thoughts, problems with concentrating, or changes in appetite or sleeping behavior. Detailed workup includes urine toxicology screening, which is negative. Which of the following is the most likely diagnosis? Let's take a look at the options. Let's leave adjustment disorder for now. Borderline personality disorder. Again, we haven't discussed this, but this usually manifests in a patient who is in a relationship. They will have a lot of attachment to the person. We will talk about that later. Major depressive disorder, no. She has no suicidal thoughts, but when we take the two answers, this seems to be more likely because the patient has a 4-year history of this condition. And the mood doesn't seem to be as low as you would see in depression. So if this was, we do not see problems in concentration or changes in appetite or sleeping patterns. It's just she has a depressed mood, which seems to be most likely persistent depressive disorder. A 32-year-old woman comes to the office due to insomnia and fatigue over the last month. She has felt increasingly depressed and worthless since being let go from her job 5 weeks ago. A week prior to her last menstrual period was particularly difficult, and she stayed in bed most of the days. Over the last month, the patient has lost 3.6 kilos and has felt unmotivated and unable to concentrate on looking for new work. Her medical conditions include hypothyroidism, but the TSH level is normal. Medication includes levothyroxine, naproxen. Physical examination is normal. Which of the following is the most likely diagnosis? The patient has had these symptoms for the last month. This seems to be a major depressive disorder. An 80-year-old man comes to the office due to disturbed sleep. He describes being unable to sleep well for the past few months and says that it has been making him feel slowed down and without energy. Okay, now this case is very important because you need to analyze this very carefully. An 80-year-old man, an old man, has disturbed sleep, unable to sleep, and the patient feels slowed down and without energy. This points to depression. The patient used to get 7 to 8 hours of sleep each night. Now his sleep is restless. He describes needing at least an hour to fall asleep and frequently awakens during the night. They are talking about his sleep. He used to drink 2 beers with his friends during card games, but cancelled these activities as he is too tired and no longer enjoys them. The patient is retired and has lived alone since his wife died a year ago. He says his appetite and concentration aren't what they used to be. There's a weight loss seen since the last visit. Which of the following is the most likely explanation for this patient's symptoms? This case is a tricky one. They tell you all about his sleep, making the person assume this could be sleep-related changes. But if you analyze the case carefully, this is a major depressive disorder. A 40-year-old man presents to the ER complaining of feeling like death. He has not been sleeping through the night, has been losing weight, and these symptoms began about 3 months ago when he discovered his wife was having an affair. He feels betrayed and starts abusing alcohol. He has stopped participating in his weekly runs and has not returned phone calls from his friends and family recently, and prefers keeping to himself. He says that he has been having frequent thoughts of suicide. He has no psychiatric history. Physical examination is unremarkable. Which of the following is the most appropriate next step in the management of this patient? He has been having frequent thoughts of suicide. He has depression. So let's take a look. The first thing you do is you need to perform a suicide risk assessment. From there, you can do the rest of the things needed.